Assalamualaikum warahmatullahi wabarakatuh and good afternoon to everyone. Thank you, Dr. Azan, for the kind introduction. Can see my slide presentation.
Yes, Dr. Rohayu, we are able to see your presentation.
Okay, thank you. Hello everyone. So for today, I will talk about pelvic fracture, early identification, and acute care treatment. So, as an introduction, pelvic trauma is relatively rare, but can be fatal due to its association with the high energy mechanisms and the risk of life-threatening hemorrhage. So, the pelvic fracture has the ability to hide massive internal bleeding without obvious signs. So, retroperitoneal space can hide approximately 4 to 6 liters of blood. So pelvic fractures are often overshadowed by more visible injuries, such as patient presented with the limbs injuries. So always consider pelvic injury in blunt trauma with shock and no external bleeding. Early identification and appropriate pre-hospital and also in-hospital management are crucial to reduce the mortality. So when we look at the epidemiology, the incidence of pelvic fracture in major blunt trauma cases approximately 9 to 13%. So due to the high trauma energy involved, severe pelvic trauma rarely presents as a single injuries. So up to 80% will be associated with the brain, thorax, or abdomen has been reported. Mortality range from 10 to 30% in the stable pelvic fracture and increase to up 50% in open pelvic fracture or hemodynamically unstable fractures. So the pelvis is a strong ring-like structure adjoining the spine and femurs, composed of the sacrum, ilium, ischium, and also a pubic bone. So each bony component of the pelvic ring is held together by a strong bands of fibromuscular ligaments. So if pelvic rings breaks, so there is usually a second fracture or ligamental injury. Pelvic bone protects the critical vessels such as internal and external iliac arteries and also veins, bladder, urethral and reproductive organs, and also bowel. So bleeding can come from the venous plexus, arterial sources like the internal iliac branches, or from the fractures of bone surfaces. So pelvic fractures injuries can be classified into 3 categories, which are the first category is stable pelvic fracture, a bone fracture where the pelvic ring remains mechanically intact due to the uninjured supporting ligaments. Second category, unstable pelvic fracture, a fracture that results in biomechanical instability of the pelvis with or without associated hemodynamic compromise. And the third category is unstable pelvic fracture with hemodynamic instability, pelvic fracture accompanied by a vital sign derangement due to the significant hemorrhage. So for mechanism of injury, often give us a clue which help us to predict the likelihood of fracture type and also the severity of fracture. High impact mechanism like road traffic accidents, falls from height, or crush injuries are the common culprits for the pelvic fractures. But in the elderly, even a low energy mechanism like a fall from a standing height may cause significant pelvic injury. So pelvic fracture can be classified by several classification systems, and the 2 most commonly used systems are Young-Burgess classification and Ostile classification. The Young-Burgess classification is more common and useful in emergency department as it is based on mechanism of injury and the stability of pelvis, but it provides little guidance for definitive treatment planning. 4 primary mechanisms that can lead to pelvic fractures are lateral compressions, the most common injuries accounting for approximately 60 to 70% of cases. followed by anterior posterior compressions. Injury is about 15 to 20% of cases. Vertical shear injuries represent about 5 to 15%, and some patients may present with a combination of complex injury patterns. So among these, vertical shear is considered the most severe and unstable, involving the vertical displacement of the hemipelvics, have a pubic rami and sacroiliac joint fractures, and it carries high risk for visceral injuries. For anteroposterior compressions and also for the lateral compression injuries, type 1 is considered stable pelvic fractures, while type 2 and type 3 are unstable fractures requiring surgical interventions. So in the emergency setting, the priority is to determine whether the pelvic fracture is stable or unstable, rather than we focusing on detailed classification of the subtypes. So because it is crucial for us to know, to decide for the early management and resuscitations in emergency department. Whereas for type classification, it is based on mechanical pelvic stability and useful in guiding pelvic reconstructions and surgical planning. So approximately 70 to 80% of all pelvic fractures fall under type A or type B injuries. And both type B and C fractures are considered unstable, which requiring surgical intervention. Okay, in the pre-hospital setting, it is essential for us to maintain a high index of suspicions for pelvic injury, particularly in cases involving the high impact trauma. So a pelvic binder should be applied early if an unstable pelvic fracture cannot be confidently ruled out to minimize the bleeding and also to stabilize the pelvis. So when you're transferring or repositioning of the patients, lock rolling should be avoided if you suspect unstable pelvic fracture, as it may worsen bleeding and disrupt the pelvic stability. Instead, you need to use a scoop stretcher for movement with a maximum lateral tilt of 15 degrees if repositioning is absolutely necessary. Early trauma team activations is crucial, as it ensures everyone's alerted about the patients and prepare for the patient's arrival. So assessment of trauma patient in the emergency department begins with a systemic primary survey and resuscitation following the CABCDE approach in trauma protocol, which is look at for the catastrophic bleeding, and then check for the airway patency and also cervical immobilizations, followed by breathing and ventilations assessment, circulations with the hemorrhage control, disability, and exposure. So during the assessment of C for circulations, a focused pelvic assessment should include inspection for the bruising over the perineum or flanks, pelvic deformity, leg length discrepancy, has a perineal or scrotal swelling, and any visible signs of bleeding from the rectum, vagina, or urethra. So palpation should be performed with a caution. So only gentle single hand compression is recommended. And the pelvic spring test must be avoided, as it can disrupt clots and exacerbate the bleeding. If there is a suspicion of rectal injury, such as from an open fracture or visible bleeding, a digital rectal examination may be warranted. These early steps are critical in recognizing the pelvic trauma and in initiating the timely intervention to reduce the morbidity and also the mortality. So the red flags for the pelvic injuries, where you should strongly suspect that patient have a pelvic fracture, especially in patient presenting with a hypotension without obvious external bleeding. So beside that, patient present with hematuria and scrotal or perineal hematoma are part of the red flags for pelvic injury. So it is important for us to maintain a high index of suspicions and not wait further imaging to initiate management if pelvic injury is suspected. So in such cases, you think of the unstable pelvic injury. So pelvic binder should be applied immediately, even before imaging, as ongoing pelvic hemorrhage is often hidden and critical, threatening to the patients. So the binder should be positioned correctly over the greater trochanter. And also need to avoid excessive or repeated manual palpations of the pelvis, as this may dislodge forming clots and exacerbate the internal bleeding. So when you should apply a pelvic binder? So pelvic binder should be applied early in the trauma patient when there is a suspicion of pelvic injury, especially in specific high scenarios. These include patients with unconscious trauma patients, polytrauma cases, and those who have sustained a high impact mechanism of injury, such as patients with motor vehicle collisions or falls from the height. Other key indicator includes complaint of pain over the pelvic regions, or when the presence of an unstable pelvic fracture cannot be confidently excluded. Sign of shock without an obvious source of bleeding following a trauma should prompt immediate binder application, as pelvic hemorrhage is often concealed and life-threatening to the patient. So this is the examples of the commercially available pelvic binder, which include the same pelvic springs on the left side and the teapot. So if a dedicated pelvic binder is not available, a folded bed sheet can be used as an effective alternative to provide temporary pelvic stabilization. So how to apply the pelvic binder? The pelvic binder should be applied at the level of the greater trochanters, not at the iliac crest or not at the abdomen of the patients, to ensure the effective stabilizations. Its primary functions are to provide circumferential stabilization of the disrupted pelvic ring, limit the internal bleeding, and assist with the tamponade and hemostasis, also help to reduce pelvic mobility and thereby contributes to pain relief in the acute trauma setting. So this article shows a study conducted at the German Level 1 hospital. This is a retrospective cohort study, consists of 66 patients with unstable pelvic fractures. And the aim of the study is to evaluate whether pre-hospital application of a pelvic binder improve patient survival and clinical outcomes. Finding from the study indicate that pelvic binders did not significantly improve overall survival, but they may still play a valuable role in initial stabilizations, provided pelvic binders are applied early and correctly. Importantly, the study highlighted concern regarding the correct application of the binder. Only 21.2% of patients was applied binder correctly at the greater trochanter. Another 21.2% were poorly positioned, and 57.6% of the patients arrived without any binder applied. Another study conducted at a Level 1 Canada Trauma Center. This is a retrospective cohort study involving 228 trauma patients with a pelvic fracture. So this study shows 17.1% had open book fractures that would benefit from pelvic binders. But pelvic binders were used in 30.3% of cases at the pre-hospital care and often misplaced. 26% needed repositioning at the trauma center. Misplacement was usually too high on the iliac crest instead of over the greater trochanters. So based on the findings from both studies, it is evidence that pelvic binders remains underutilized in the management of pelvic fractures. And when applied in the pre-hospital setting, they are frequently positioned incorrectly, often requiring readjustment upon arrival to the emergency department. So investigations and diagnostics tools in pelvic fractures include the laboratory testing and also imaging to help to assess the extent of trauma and to guide the management. So for the laboratory testing, trauma panel should be obtained, include the full blood count where you want to see mainly the hemoglobin, the platelet, and also the coagulation profile, fibrinogen, bleeding times, blood gases, renal profile, liver function test, electrolyte, troponins, and also urea FME. For imaging studies, need to perform primary X-ray, which is your mobile chest X-ray, and then pelvic X-ray. Pelvic X-ray should be performed early, especially in the unstable patients, because the pelvic X-ray is a fast and effective in identifying key injury patterns such as open book fractures or symphyseal pubic widening. EFAS is useful for identifying intraperitoneal bleeding, but it's limited in detecting the retroperitoneal hemorrhage, which is common in the pelvic trauma. CT scan reserved for the hemodynamically stable patients. What CT scan you want to order depends on the suspected injury of the patients. Whole body CT, you may order it to identify pelvic fracture and the associated injuries. CT of the pelvis will provide detailed anatomical informations, aiding in the classifications, surgical planning, and identifying the active bleeding for potential angioembolization. Certain cases, you may need CT cystography to detect the bladder ruptures or even CT angiography to detect and to localize the actual bleeding and assist in decision for embolizations or surgical control. So the pelvic X-ray on the left side demonstrates a vertical shear injury on the left side of the pelvis with the bilateral superior and inferior pubic rami, and the corresponding 3D CT reconstructions on the right side further delineates the fracture patterns in the greater details. So based on the initial plain X-ray, the presence of the unstable pelvic fracture can be identified. Whether with the CT imaging, it provides more comprehensive assessment of the fracture configuration and the extent of the displacement. So this is an algorithm that you can use in managing the unstable pelvic fracture. So in case of unstable or you suspected pelvic fracture or pelvic fracture which you cannot roll out, so apply the pelvic binder as early as possible. So keep the pelvic binder until you can roll out by either clinically or radiologically or after surgical control. So initial imaging should include the primary pelvic X-ray to rule out the open book fracture, along with the fast scan to identify the associated intraperitoneal bleeding. Subsequent management depends on the patient's hemodynamically status. So in the hemodynamically stable patients, CT scan of the abdomen and pelvis is recommended for detailed evaluations and planning of the definitive care. But in hemodynamically unstable, we proceed with the damage control resuscitations, which include our permissive hypotensions if there is no traumatic brain injury, hemostatic resuscitation, including the activations of massive transfusion protocol or targeted massive transfusion protocol. And you should give patient tranexamic acid within 3 hours of injury. And if fast negative, then the bleeding source is likely at the pelvis, and the patient may require pelvic fixations or surgical hemostasis or angioembolizations of bleeding pelvic vessels. If FAST is positive and intraperitoneal hemorrhage is suspected, then the patient should undergo immediate surgical intervention and exploratory laparotomy or damage control laparotomy. So identifying the source of bleeding is crucial. Always consider that patient has a concurrent injuries in the other body regions, such as abdomen or thorax, which can contribute to the hypovolemic shock. So when to involve the surgical teams? So when patients remain hemodynamically unstable despite applications of the pelvic binder, ongoing blood transfusions, so we need the surgical team involvement. In such cases, urgent intervention is needed to control the bleeding and stabilize the pelvis. So orthopedic surgeons may proceed with the external fixation to provide mechanical stabilizations. If atrial bleeding is suspected or confirmed, IR or interventional radiology may be required to perform angioembolizations of bleeding vessels. And if there is evidence of urethral or bladder injuries, such as blood at the urethral meatus, urology consultation should be initiated promptly. And while general surgeon may perform pre-peritoneal pelvic spacking as part of the damage control surgery in presence of the intraperitoneal bleeding. So what is the common pitfall to avoid in the management of patients suspected pelvic fractures? So never perform the pelvic spring test. This maneuver can destabilize a fracture further and worsen the hemorrhage in patient with an unstable pelvic injury. And avoid lock rolling as it may exacerbate the bleeding. Delay recognition of pelvic instability. This can result in the missed opportunities for early hemorrhage control. Delay and improper pelvic binder applications will reduce the effectiveness of the binder. Delay in trauma team activations may delay access to the definitive interventions. And waiting for imaging in hemodynamically unstable patients, it will delay the critical interventions. And the last is a missed occult retroperitoneal hemorrhage when only relying on a fast scan alone, because retroperitoneal hemorrhage is common in the pelvic trauma and often not detected on the ultrasound. So collar the neck, collar the hips. It's just a term for as a principle that emphasize the need to assess for the pelvic injury and consider the pelvic immobilizations in any patients who require a cervical collar. Unless the patient is fully alert, can communicate, and able to reliably exclude pelvic pain or injury, then you can rule out the pelvic injury. This approach to ensure that potentially life-threatening pelvic fractures are not missed during your initial assessment. As a take-home message, always suggest a pelvic fractures. Always suspect a pelvic fractures in patients with a high energy trauma, especially when presenting with a sign of shock, but there is no obvious source of bleeding. Apply a pelvic binder promptly and liberally in suspected open book fractures or when pelvic instability cannot be ruled out. And ensure correct binder placement. So the position should be at the greater trochanter, not at the abdomen, not at the iliac crest. This is for the optimal and effectiveness of the binder. Early recognitions, timely and effective pelvic immobilizations, and appropriate resuscitations are the critical to improving outcomes in patients with an unstable pelvic fracture. So this is my references. And with that, thank you.
All right. Thank you very much, Dr. Rohayu, for that pearls of pelvic injury on how we should approach and resuscitate a patient with pelvic injuries. That was enlightening for all of us. So right now we're going to go for a short break and a word from our sponsors. And we'll be back with the second part of the CME and also a Q&A session. So just a reminder, if you have any questions, please put it in the Q&A segment and we'll get the speakers to answer your questions and give their inputs and their thoughts. All right, we'll go for a short break and we'll be back.
Ultrasound is a useful tool to help you in determining the cause of shock, but it can be complicated and take time that is limited. With input from hundreds of ER and critical care physicians, we created Venue, a system that simplifies the complicated steps. Venue's Shock Toolkit is a set of features that focus on some key indicators of patient status: the heart, lungs, and IVC. It assists you in gaining insights needed to help in the determination of the cause of shock.
I'm Jim. Today, I will demonstrate the operation of a metal tourniquet. Compared to a plastic tourniquet, the metal tourniquet is stronger, more durable, and suitable for multiple uses. It provides stronger pressure, making it ideal for dealing with severe bleeding. Let's get started. First, retrieve the tourniquet from your first aid kit or tourniquet pouch. Slip the wounded extremity through the loop of the self-adhering band, or route the strap around the limb. Ensure all slack in the self-adhering band is pulled through the routing buckle before fastening the band back onto itself and twisting the windlass. Twist the windlass rod until the bleeding is stopped. Lock the windlass rod in place with a windlass clip, secure with a windlass strap. Record the time of tourniquet application to facilitate subsequent medical treatment. If no other major bleeding is found, move the casualty out of direct fire.
Why the Score-to-Canto catheter? The Score-to-Canto catheter has a larger inner diameter than standard suction catheters. The larger inner diameter has many advantages. It allows for larger pieces of emesis to pass through to the collection canister. It also makes it significantly less likely to clog in an emergency situation. The Score-to-Canto catheter has no thumb port. This delivers constant suction throughout the procedure. Pre-assembled kits with suction tubing are available in a plastic pouch to help speed things up, like in an emergency. The kits are packaged with 6-foot or 3-foot suction tubing. Score-to-Canto catheter kits are connected to a flexible suction tubing that has a 9/32 inner diameter for maximum flow. The Score-to-Canto catheter is the ideal tool for the salad technique. There's much more to learn at score.com.
All right. Welcome back to the second part of our National Trauma Series CME. So we've already had a lecture about the resuscitation part and early identification. So next we'll proceed with a surgeon's perspective in regards to managing a pelvic trauma. But before that, we would like to remind you a few housekeeping messages. Registration QR code will be provided at the end of the CME. An e-certificate will be sent to your registered email, and it will take about around a month or so for you to get the certificates. Don't forget to check your spam or junk mail if you haven't received it in your primary mail. Registration via the QR code will be closed 15 minutes after the event, and successful registration within a period will be awarded with the e-certificate. All right, so the next speaker is someone that we brought all over from Sabah. Dr. Timothy Cheng has served Sabah since 2012 and currently is an orthopedic surgeon in the Hospital Duchess of Kent, Sandakan. He is the current Malaysian Orthopedic Association Treasurer. He is the chair for MMA SCOMOS. Apart from clinical work, he's also very active in public health awareness, sports, and charity events. He is a member Academy of Medicine, Malaya, a member of Royal College of Surgeons of Edinburgh, and a certified medical impairment assessor from NIOSH, right? So that's longest. And to add on, he's also one of our TLSM trainers. So now we'll like to give the floor to Dr. Timothy Cheng for his topic, pelvic trauma, surgical intervention, and indications. Dr. Tim, the floor is yours.
Hi, Hassan. Hey, thank you for the kind introduction. Let me share my slides. Okay, can you see it?
Yes, we can see your slides clearly.
Okay, thanks, man.
All right.
Yes, so hi everyone. There are 116 people on a Thursday evening. Thank you to Mascot, to Azan, to Rohayu for having me here. I think it's a privilege to present to such a large crowd. And I'm also very appreciative of my emergency medicine colleagues, a lot of which I've learned a lot from ever since I was a house officer. And even more so as our new DG is also from emergency medicine. So we look forward to an exciting time in KKM. I think Rohayu has gone through most of the stuff that you need to know about pelvic fractures, and I'll just add a very little bit from a perspective of an orthopedic surgeon when it comes to pelvic fractures. We are not very useful in ED, to be honest. We are more useful in OT, but this is what runs through our minds when we get a referral for pelvic fracture. So this is me, the hospital I work in, and I have nothing to declare. And these are some of the associations that I'm involved in. So very quickly, the overview of pelvic fractures from an orthopedic surgeon's point of view, the introduction, the diagnosis, and a very quick bit about management and what we can do in the emergency setting. So like mentioned by Rohayu, our pelvis is a very important part of our body because it connects our exoskeleton to our appendicular skeleton. So basically our spine to our legs lah. And without the pelvis, we won't be able to walk or sit or function. And throughout this whole presentation, if you don't remember anything, just remember the ring, okay? And this ring will develop the fundamental understanding of how and why we treat pelvic fractures and the stability of the fracture. Something a bit more closer to a pelvic ring would be like a polo mint rather than the Lord of the Rings. Now, if a polo mint is cracked in one place, basically it's stable. If you crack a polo mint in two places, the whole mint will just fall apart. So essentially is to remember that in this ring, if the ring is broken in one spot, you are still kind of safe lah. Okay. If it's broken in two places, that's when you are worried. And that's when we are all worried. Yeah. Okay. I won't run through this. This is just basically to say what kind of ligaments there are around the pelvis and how strong it is and why we are concerned. So in TLS, in this ABCDE, the pelvis comes here in circulation or rather in bleeding lah. Yeah, so that is why we are worried about the pelvis injuries. And like I mentioned earlier, retroperitoneal bleed can be in fact more than 2 liters. And this is why, because there is a lot of vasculature around the pelvic ring. You would think that arteries bleed more, but in fact, arteries, they can have spasm, they can clot up, and veins are the venous plexus is the one that can bleed and can bleed slowly, in fact, over 1 or 2 days. And I will illustrate that in an example later. So a history of a pelvic injury, or rather the one that concerns us and one that is worrying or urgent, is one of high impact. And if you look at the kind of impact that needs to fracture a pelvis, is anywhere from 3 to 5 tons. So 30,000 to 50,000 newtons. So 3 to 5 tons is a good lorry basically, running at you and smashing you. So always, like mentioned earlier, remember to look for other injuries. Again, already mentioned, I'll just run through this quickly. Palpate and not spring, and look out for, any deformity, any bruising around the abdominal area or pelvis area. Okay, this is about springing and why we should not spring anymore. And really to diagnose a fracture, one of my mentors previously taught me is really by just looking at palpating, and if you actually confirm a fracture by doing an X-ray. And these are the kind of X-rays we do, and the importance again of doing an inlet and outlet view. And this is just in case you're not sure or you're in a center where you have to operate the X-ray yourself. Hopefully not. This is where the inlet and outlet is lah. And the reason why we do inlet and outlet is because you can see very, very different fracture configurations from both. Okay, so on AP, you would essentially remember the ring again. So if you see that the ring is only, maybe there's a slight widening of the symphysis pubis, you will not be so worried. So in this ring, there are two main areas. One is when I look at an X-ray, I look straight at the symphysis pubis and the SI joint. And if the symphysis pubis is not widened and the SI joint is intact, I can relax for now lah. Yeah, and of course the other lines are also important, but not as important. And these are the lines that form the acetabulum and the anterior and posterior columns of the acetabulum. So again, the inlet is also the pelvic ring, and the outlet, you would want to also look for vertical shear, as you can see on the second X-ray here. Okay, also mentioned just now, for me, I look at young hamburgers based on mechanism and tile based on the pelvic instability. And this is demonstrate how the pelvis can fracture, whether it's front and back or from the side. Okay, and you can actually overlap both APC and tile to form a sort of combination. So basically a tile ABC you see, and the young hamburgers who LC ABC1 will be stable. Okay, then you got vertical and rotational stability in the yellow color area, and APC3 and vertical shear would be both vertical and rotational unstable. This is if you want, I mean, it's more for academic purposes lah. Yeah. Okay, why we do inlet and outlet, again, on AP, it may look very normal, but when you do an inlet and outlet, you may see something different. And so this is also the reason why you should always get an inlet and outlet view, because it might not, on initial X-ray, be so obvious. Also mentioned, just a tip, if you're not sure where to put the pelvic binder, make sure that if it covers the umbilicus is wrong, it should always cover the suprapubis area, and then that means you're correct. Also, I mentioned earlier by Rohayu. So yes, let's just go very quickly to this. Say a patient comes in like this, and it's a patient we got in Sandakan. So the question is whether to bind or not to bind. And I'm sure the thing about binders is that it's usually placed in pre-hospital care, which is correct. So you always bind if you're not sure. But when you come to ED and you do an X-ray and you have this, say you had not put a binder on before this, do you bind or not? But anyway, the answer for this is no. You should not bind because, again, remember the ring. Okay, again, as orthopedic surgeons, we are just thinking about whether that ring is intact. Now, if you look, the ring is actually intact. And in fact, if you bind this, you will end up pushing the head of femur into the pelvis, and you actually worsen the fracture if you bind. Yeah, so the treatment for this patient is basically just to catch up the bleeding, and you can put a traction on the left lower limb for pain relief and to prevent further displacement into the pelvis lah. But putting a binder on, in fact, if you can imagine, if you press on the GT this way, you would actually push that bone inside. But anyway, this patient went home well. I'll show you the post-op X-ray later. So when to remove the pelvic binder, I think that's also another question that we always ask ourselves. I ask myself sometimes. It's a very difficult question to answer, but again, is to look at the pelvic ring. And if you're not sure, to leave it on, and only after an X-ray is done, of course. And if you're still unsure, then do ask your orthopedic surgeon colleagues. But it's safe to say that if the ring is intact, it's okay to remove the binder. Okay, I think Rohayu also went through this, when to place the binder when the pelvic ring is unstable. Very quickly, just for completion's sake, this is the Jude views of the acetabulum. Again, it does not affect directly the integrity of the pelvis or the ring, so you're not so worried about this. But it's to say that Jude views are taken in 45 degrees, and this is what it looks like lah. Also for academic purposes, it's a very complicated classification, but this is the acetabular fracture classification. Okay, so we come to surgical management. And if you think about it, in actual fact, the only thing that surgical management in acute management of pelvic fractures does is to replace the binder. Again, we're back to the same ring that we keep talking about. So in an emergency, you remember the vasculature of the veins. When that bleeds, the idea is to close the ring, close the open book, and wait and let your FFP, your PEG cell, your platelet catch up the coagulation cascade to stop the bleeding and to maintain that ring there to achieve a tamponade effect. So, I mean, you can't leave a binder on, obviously, for a long time. You get pressure sores and everything else. So the only reason you want to put an X-fix is to basically replace the role of the binder. Now, so we had this patient that just came in fact, a few days ago. And I'm not supposed to show the CT scan, but anyway, so the HP dropped from 13 to 7.8. Platelet also dropped. Tachycardic, class 2 shock, transfused 4 pints PEG cell, and it was still low. After that, the CT pelvis showed a sacral alar fracture. If you look carefully, there's also fracture here and there. And really, there is no role for any binder or surgical intervention because, again, the ring is intact, and they ruled out head injury, chest injury, no intra-abdominal bleed. So the only place left, he had ankle fractures which will not bleed so much, is basically that venous plexus around the sacral ala. And short of doing peritoneal packing, which we did not do, I have never done it before. And surprisingly, this is actually from the Orthopedic Surgery Reference website. If you Google AO Surgery Reference, you'll see it's like the handbook or Bible of orthopedic surgery. They actually describe pelvic packing, and this is what it does. And this is how the packs actually compress on the blood vessels to stop the bleeding. I'm not sure whether the trauma surgeons here have any experience, but I myself do not. Yeah, but I'm just, perhaps someone could share. Yes, so this is what an X-fix looks like. I'm putting it here because I'm not sure about Malaysia, but I think it is something that can be done, in fact, bedside with LA, and not just by orthopedic surgeons, but I think anyone that is trained in trauma surgery. And the reason why there is a space and it looks like this is to allow room for the general surgeon to perform the laparotomy and stop the bleeding. There are usually two places we can put the pins. One is above the acetabulum, it's a bit stronger. And the supraacetabulum is basically, the iliac crest is where it's easy to put and can be done, in fact, bedside with some LA. And you don't even need a sterile drill. It's like putting your intraosseous needle, your drill can be non-sterile as long as your pin is sterile. Of course, this is not the ideal situation, but in austere and resource-limited settings like maybe Sandakan, or other places in Malaysia, you can actually try this. So you pinch the side of the iliac crest. After giving some LA, you make a nick. You watch out for the LFCN here. There's a nerve here. So you go 15 millimeters above the ASIS. And essentially, you just drill a pin in. It seems it sounds a lot simpler than it is, but it really is that simple. And you drill and you make sure that the pin does not come out either the inner table or the outer table of the pelvis. You assemble the pins, and like the pelvic binder, you compress in the GT. After you close the book, then you just tighten on the nuts and you're done. That's essentially that's what we do in OT. And it really can be done bedside if the need is there. Yeah. So again, back to the patient you saw earlier. So we took her to OT, we put her on traction, left lower limb, and then we took her to OT about a couple of days later, and this is the eventual definitive fixation, which is basically usually a combination of screws and plates, or sometimes only screws or just plates. You would wonder why that screw at the back is there, okay? And that's because there was some SI joint widening. So again, you remember that ring? Okay, so it's to strengthen. You see the ring in front, symphysis pubis is intact, but the SI joint was slightly widened, so we just reinforced that with a screw. And if you look at the post-op X-ray, it's again creating that ring and maintaining the ring. It can also be done basically by screws only. This is a different patient. Yep. Yeah, so actually that's all. I know it's a very short thing, but yeah, there's really nothing much to add in terms of surgical intervention for pelvic injuries. Yes, if there are any questions, I'll be happy to take some. Thank you. Sorry, Azan, pendek sangat kan?
All right. Thank you very much, Timothy, for such a concise lecture and CME on pelvic injury, a surgeon's perspective. I think that was very enlightening for everyone. All right, so we're going to do a quick Q&A session. So I have a few questions here that probably you can ask the panel to address. Some from our speakers, some from our society, and also some from the chat. All right. Okay, so I have the first question. And the first question here is actually for Dr. Timothy. And it actually came from our very own Dr. Sabaria, which is our previous national HOS. Hi, Dr. Sabaria. So,
Hi.
Dr.
Sorry, I'm not on the video, just my
Oh,
voice.
yes. Hi, Dr. Sabaria. Assalamualaikum.
Salamatullah.
Okay, so you boleh tanya soalan sendirilah kepada surgeon kita.
Hi, Dr. Timothy.
Yeah, I saw it.
In very acute conditions where we have very bad retroperitoneal bleeding, right? What do you think the role of retroperitoneal packing? Because that's
Okay.
because we do need to pack the peritoneum, especially when there's a lot of, especially the venous bleeding, when we have venous bleeding.
Yeah, I totally understand the question. In fact, it's something that I would like to ask you or general surgeon, because I have never done any retroperitoneal packing. I don't think any orthopedic surgeon would go into that area. In fact, the last one we had, so that same patient that I shared, I actually called up ONG and asked them, do you have any experience? Because there's no role of putting any metal or any implants
Yeah.
out there. So, they said, oh, they're not going to pack. So I said, okay, let's just transfuse and wait, because, there's no way I'm going to open the peritoneum and look at it. This out of my this one. But I don't know, if anyone has experience from trauma surgery or maybe HKL or some very busy, war zone or military zone that could share, it'd be very interesting. But no, I have never done it before.
I know the trauma JB guys do it. I'm not sure others do it too. But that seems to be the packing that you need if you really have. As you say, there's in some cases there's no role in putting up the what do you call that, your implants, the external fixators, right? You just need to just stop the bleeding immediately by the packing. In JB the surgeons do it, so but you can go for a course. Maybe Dr. Shah, part of the your cadaveric course, Zania, part of a cadaveric course, you maybe can add this retroperitoneal packing, because I have also, I'm not a surgeon, so I have really no idea how and where they go. But all I know is it's a suprainguinal incision. That's all I know.
Yeah, it's the same incision we use to plate the pubis actually. You can slide to the back. Just that, yeah, I've never done that before.
Yeah. So maybe that's one of the courses that you can take, and the orthos and the surgeons can actually attend the course, your cadaveric course, and learn how to do a cadaveric, how to do a we call it periperitoneal packing.
All right. Thank you so much for the input, Dr.
Nice
Sabah.
talks, both of you all.
All right. So it's something that probably we can consider in our future training, and maybe it can be a collaboration with the orthopedic team also for this type of procedure. All right. Thank you, Dr. Sabara, for that. All right. I have one question for Dr. Rohayu. Sorry. So the question is, you explained just now in your presentation that we should not do a pelvic spring and lock roll in an unstable pelvic injury. Maybe you can explain a bit more details in regarding to that statement.
Thank you, Dr. Azan, for the question. So basically, in a patient with an unstable pelvic fracture, if you do a pelvic spring or lock roll, because you move a patient where the patients already have a unstable pelvic fracture, when you do a pelvic springs, you will disrupt the fracture. And then also patients usually patients are with the patient unstable pelvic fracture, they have already a clot formations inside that. And when you do it, this lock roll or you do a pelvic spring, it will disrupt the blood clot and also can cause a further bleeding, which can patients from unstable pelvic fracture, when you put your binder and then you do a lock roll again and again, the clot disrupted and then bleeding again. So from unstable become stable and become unstable again. So I think that's That's why we didn't do the pelvic spring, but what we do is only a gentle palpations. If there is a fracture, it will not cause further disruption of the structure of the pelvis. And if you're gentle palpations, you just know patient already, and you palpate, patient already complain of pain. So no need to do a very your pelvic spring anymore. Okay.
All right, so that's a reminder for everyone. We now move away from doing a pelvic spring and we go for a gentle pelvic palpation, single hand, right? Okay, Dr. Timothy, we have another question for you. This came from an anonymous attendee. Hi, doctor. Is it true that pelvic binder is contraindicated in lateral compression fractures, as it might cause the fracture to displace further?
Yeah, okay, that's a very good question. I think we need to understand, like presented by Rohayu just now, that pelvic binders, it's not like you got splitting artery, then you just compress, and then you let go, you bleed, you put it there, you let go. It's not that kind of concept. So it's not to say that, and look, even if you look at statistics, it's not to say that once you put a pelvic binder on, the bleeding will stop immediately. So it's definitely something you put on at pre-hospital because you don't know whether the ring is intact. Okay, so it's shown that statistically, by putting it on is better than not putting it on. So you put, but after you come back and you realize that it's an LC compression fracture, or you realize that the ring is intact and it's say protrusio. Protrusio means that the head of femur has gone into the pelvis, and then you can remove the binder. But of course, by the time you get the patient to the hospital and you refer, and there should be an orthopedic surgeon there, or at least someone from the orthopedic surgery team, and then they would advise you lah. But if the fellow is still sleeping in OT or cannot be contacted, then, and the ring is intact, and you see that, by the pelvic binder it's actually causing further displacement, then it's actually okay to remove it lah. Yeah, and if you're unsure, you can actually repeat another X-ray after you remove it. And that can be done in a couple of minutes lah, sure. But again, this is a lot of caveats. Only if you cannot this, cannot that. And ideally is to get the patient there, trauma activation, orthopedic team is there, to look at the X-ray. Okay, this is that. But yes, theoretically speaking, if it's lateral compression, you actually don't want to bite. Yeah.
All right. Thank you for that. So, but you always, like you said, when the patient at pre-hospital care or during resuscitation, before we're able to do the X-ray, we won't know what type of fracture, whether there is a fracture, and if it is, what type of it. So, for the patient safety,
Yes, that's fine. Correct.
Placing it first, and then once we've done our primary survey and primary X-rays or CT, then further discussion can be made. All right, I think that was an amazing CME. It was a very good Q&A session. I would like to thank again to Dr. Sri Rohayu and also Dr. Timothy Cheng for their wonderful presentation and helping us to enlighten and remind us regarding management of pelvic fractures, both in the ED and also in the OT and the consideration. So with that, I thank you very much, and hopefully we're able to meet again next month and we manage to collaborate again in the future. So thank you so much. Take care, and all the best. Thank you.
Thank you, Azan. Thank you.
Thank you, guys.
Thank you, Azan.
All right, team. So that was amazing. Thank you, Dr. Rohayu again, and Dr. Timothy Cheng. So now we will set you up with the QR code for your attendance. So you have 15 minutes to scan and register, and hopefully, thank you. And
Thanks, bro.
hopefully, thank you, bro. See you again.
Yes, catch you later.
Yes. So yes, and hopefully within 1 month, we will be able to give you the set. All the best, take care, and till we meet again. Assalamualaikum.